I'll start a new recording for the lecture. Let me upload this on the PowerPoint before I forget. Not on the PowerPoint, on the Canvas. Oh my God, my brain. Hold on. By the way, I have your tests. We'll do it at the end of the lecture. Okay, so we're changing gears now. We're doing from here on, we're going to study infectious diseases. How we separate the infectious diseases is by system. So respiratory infectious diseases, cardiovascular infectious diseases of the skin, and so on and so forth. How you study for this is now different. First of all, in all systems, the key thing that you need to know is what are the protective measures that the system has. So the immunological protective measures. So for example, for the skin itself is a protective measure. It's your barrier. So all the things that we talked about when we talked about skin and what are the characteristics of the skin that makes it a good barrier. Second thing that you need to know is whether or not in each system do you have normal flora. And if you have the normal flora, where is the normal flora found in the system? Anatomy, physiology, this is not the class for it. So I might say it, like just to introduce to you guys, okay, this is the system we're talking about, this is what it covers, but you are not responsible for telling me what neurons do, how is the nerve impulse is created. That's for your anatomy, physiology class. Enjoy. All right, so here, like I said, just immune and protective measures and normal flora. Then I start talking about the infectious diseases. Only worry about the ones that I have in the PowerPoint. So if the chapter in the book covers a disease that I don't talk about it in the class, you're not responsible for knowing it. I separate them based on the pathogen. So I usually go bacterial first, then viral, fungal, protozoans. Okay? Elements, I'm not covering it. Even in digestive system, I don't cover it. So if I talk about it, you need to know it. When you need to know it, you need to know the name of the disease, the name of the pathogen, possible signs and symptoms, treatments if there is any, preventive measures if there is any, and possible prognosis. And what I mean for prognosis, for example, for Lyme disease, even after the person recovers from it, majority of the patients form severe arthritis later on in their life. So that's a prognosis for it. Endocarditis, possibility of damage to the heart valves, heart murmurs, and things like that. Prognosis, all right? So what is possibilities of this becoming long-term or having long-term effects? My advice to you guys is to either create little cards for them or tables and color code, whether it's bacterial, viral. So you write the name of a bacterial disease, let's say in green, the name of the pathogen in green, and virals, you do it in red. That is so on the exam, that color will pop into your head, and you're basically based on that can make some conclusions. The conclusions can be things like, if it's bacterial, we obviously have, can have many treatments for it because it's antibiotics, we have a variety. Viral, it's either call me in 10 days and tell me how you're doing, take supportive care, or I'm so sorry, funeral arrangements, things like that. Because we don't have a lot of antivirals. Fungals, again, depends. It makes a difference. Immunocompromised, immunocompetent. These are things that you should remember, like words. Would it affect a person that has a very strong immune system? Is it a big deal in them? Yes, no. What about a person who's immunocompromised? Should I worry about that person? As far as the signs and symptoms go, many of them in the system will share some basic signs and symptoms. Respiratory, you bet you can hear about the person has a cough. Now, is it a dry cough? Is it a wet cough? Is it a bloody sputum production? Is there shortness of breath associated with it, damage to the lungs, things like that? And as I go through it, I try for each of them to give you that little distinguishing characteristic that separates that disease from the rest of them. So try to focus on that, those little changes. Re-listen to the recordings and see what am I putting fingers on, all right? Like in digestive system, another one. Most often cramps and diarrhea. Now, you have heavy diarrhea, light diarrhea. You have greasy diarrhea versus rice water diarrhea. You have this, that, bloody diarrhea. So seriously, that is a difference. Sometimes the diagnostic differences is how fast the signs and symptoms are coming. Sometimes it's in, all right, we got the pathogen. The pathogen is a gram-positive this. The other one is a gram-negative that. So if it is something like that, I will put it in the questions. All right, so try to do that. Quiz yourself on it. All the exams, both the remaining exams are going to be multiple choice and multiple choice only. Okay? So you don't have any short essays or anything about it. But it can be confusing and can come up with ways of memorizing it. I also use case studies. Your book has few examples of it, each chapter, but the case studies that I use are typically something that I've gone and out there and searched from MMRs, morbidity, mortality reports that they send. We had such and such patient came. Those are very technical, so I'm not using that kind of technical. I've used examples from there and then put my own wording for it, simplified it. So in case studies, I might give you a story of, yeah, this kid came to the hospital, the parents brought the kid to the hospital, the kid had a cold, usually very healthy, had a cold symptoms and all of that, and now suddenly the kid keeps tugging at their ear and keeps crying and doing this with and when you look at the eardrum is red. What do you think the kid has? Ear infection, right? So something like that. Or I might even tell you the person has this disease and ask you a question. So is a paragraph followed by like 2, 3 multiple choice questions associated with it? My purpose, my intent is not to fool you. But you guys, it's amazing. Everybody comes after the test. I give the test back. It's like, that was my first choice. Then why did you choose the other one? I don't know. I thought you were going and this one little thing that you had, it's like, okay, everything is pointing to disease A, one little thing, and you're like, it's disease B. It's like, no, go with that. Go with you. This is what is going to happen in the healthcare. Not everybody's going to have the symptoms perfectly like the textbook, and you're like, perfect. If that was the case, why did we even need doctors, right? So, no, just go by that. I'm not trying to trick you and all of that. Sometimes patients have odd little symptoms that come and go with it. So, again, go by your first instinct. People say, okay, is it harder than the first ones? I can't tell you. It's a totally different exam. It's a totally different way of studying. So modify it. Yes, there is memorization associated with it. Try to come up with ways of remembering, distinguishing them again. Let's see. All right. One other thing is, like I said, how all of them separate the bacterial viral ones. For the skin, and as I finish talking about the bacterial, I'll make a specific point. For the bacterial infectious diseases of the skin, there is 3 bacteria that I would like you guys to just create those on the side and say, it's actually Staphylococcus aureus, Streptococcus pyogenes, and then Staphylococcus epidermidis. These 3 can cause multiple diseases, all right? And I want you guys to have that in front of it. It's like Staphylococcus aureus and Streptococcus pyogenes can actually produce 2 different diseases, and they can be there. So I want you guys to memorize those. So on an exam, I say such and such disease can be caused. Then if you memorize it by individual, you know, okay, both staph and strepto cause this. So these 2 choices are the right ones, just for the skin. The rest are totally different. Marius.
So is this, like, from now on, when we talk about microbial diseases with the skin or something like that, is this kind of like introductory to how we're studying in anatomy, or is this like microbiology specific and anatomy, like, just get the cover?
Anatomy is just study of the system, what the system does, and we're not studying that. We're just studying the diseases that you can have associated with the system. One final thing has nothing to do with the exam. I'm not a physician, so I am interested, so I do study a lot about these things. Don't bring me a picture and say, what do you think this person has? I don't know. The other thing, especially with the skin, as I start talking about it, I know the students do this. You're gonna see these. This is absolutely normal for any person who studies diseases. You're gonna go home and cough twice, and you're gonna be like, I have TB. I know it. So we do think about it like normally. I do cough when I take a deep breath and I do this. This is my normal body thing. So people become hypochondriacs, and it's normal. It's okay. But trust me, if you have some of these diseases, there is way other issue things that you will have, and so it's not going to be that. All right, we're good? Okay, so different, Marius.
I was going to say, have you ever had those extreme cases where people became suspicious of any disease that you taught during a class?
Yeah, some people I've had come and say, do you think I have a fungal infection? I'm like, are you walking normal? Everything's good? Do you have a fever? Are you coughing up blood? No? Okay, you're okay. So it is. There are people that do that. All right. Usually doctors are the worst patients. Okay, microbial diseases of the skin. So again, these first parts of it, I go fast through it because it's functions of it. We know the most important function of the skin. It is our #1 barrier. So it is supposed to protect us from anything outside of our environment, pathogens from getting in. It has other functions too, like sensory functions, heat, detection of heat, the texture, things like that. Temperature regulations and all of that. But here, that's the most important one that we actually pay attention to, being a barrier against microbial invaders. Positive, the protective measures. It is a protective measure. It is a barrier. Why? Because it has, remember, the epidermis layer. It has the dermis layer. It has the sweat glands. It has the sebaceous glands. It has the enzymes lysozyme. It produces collagen, keratin. So all of the things that we talked about it. It has fixed macrophages in the area, dendritic. By the way, macrophage of neurons is microglia. And everybody was going for Kupffer. And that's for liver, microglia. So we have dendritic. Normal biota, we do have a lot of them, a lot of different bacterial. Staphylococcus epidermidis is the predominant one. We do have fungal normal flora too. Candida, Malassezia furfur can be all of there on the skin. Would they provide antagonistic? Pretty much no. They don't, and it's just commensalistic. It's not mutualistic at all for us. All right, now going to diseases. So bacterial diseases we'll go through, then viral, and fungal is very little, and I'll tell you guys when we go. Few terms that we have everyday way of referring to it, and dermatologists have their own specific terms for it. So macule is a flat, even change to the skin. So the color of your skin becomes either darker or lighter. That's a macule. It becomes a little bit redder. That's it. Drier than the rest. Then when you have a raised bump without fluids, that's a papule. If it has fluids, like it's a pimple, it's a vesicle. And then rash is a combination of two or more of these. Like the color changed to pink, and now you have pimples, kind of. Like, or hive, for example. It's bumped, it's raised, but it's red too. So combination. Blister is a term we use when dermis layer separates from epidermis together, and then there's fluid filled in the middle of it. And this is one of the reasons that they say with blisters, be careful, hold your blisters intact as much as you can. Why? Because that's the entire epidermis. So if it breaks, your dermis underneath it is completely exposed. So that's why they say be careful. All right. So let's look at bacterial infections. The most common infection, we don't even think about it unless we have the cystic form, acne. Acne is actually caused by normal flora. The dominant cause is Propionibacterium acne. Okay. The term that I have up there, diphtheroid, it has to do with what it looks like under the microscope. They are broad, but this is first was seen in the bacteria that causes diphtheria, a respiratory disease. When they, let's see. So they're broad, but when they divide, they basically divide, first of all, in not equal sizes. So they divide, and one might be larger than the other. Now, rather than either being in a chain or separating completely, when the bacteria divides, the other one flips to the side. So they are at odd angles to one another. This one divides and can put a little one there. This one can again divide and put something like that. They call it palisades. This method was seen in like diphtheria first. So there are other bacteria that do that. Eventually they might separate, but they clump together. They say it's like the Chinese writing characteristics. You know how you have different like Chinese and Japanese. So it looks like that, they stick together. And that's all it is. I'm not gonna ask you guys about it, but that's all it is. Now, acne happens typically after puberty, we start seeing it. It has to do with the change in the chemistry of the body and the chemistry of the oils. So the oil production usually increases and the texture of the oil becomes different too. It gets trapped in the pores. With it getting trapped into the pores, then traps bacteria there, and most often Propionibacterium starts overgrowing and starts causing inflammation. Now, for a person who's never had acne or they've never had cystic acne, they always go, well, wash your face, clean it. It's because your hands are dirty and you're touching it. It's like, no, you have no clue. It has nothing to do with that. Actually, for some individuals with that, the more they wash it, the more hurt the skin gets, the worse the pimples and the acne are, because it causes a more severe inflammation. A person with cystic acne creates an over response in the inflammation, which causes damage to the area. So as far as, again, it's genetics, in most cases, it tends to get better over time. What are the possible treatments? Possible treatments, antibacterial ointments on the surface, medications that change the pH and the oil production, exfoliating kind of medications so the top layer of the skin dries out and exfoliates so you have less of the bacteria on the surface of skin. Hormonal treatments, in some cases it works. So for each person it's interesting. It's not one works for everyone kind of a remedy. The person has to find their own thing. All right. Cellulitis. Cellulitis typically is when you have the basically infection in the dermal layer, so it gets subcutaneous. And typically cellulitis happens more in individuals that have skin issues to begin with, like eczema, psoriasis, acne, or something like that, or individuals whose immune system is a little bit weaker than others. Because skin, remember, it's supposed to protect you. So what ends up happening, signs and symptoms that tells you something is happening. So obviously you can have vesicles, so pimples that have bacterial growth in it. At the site, even if you don't have, it's a redness, swelling, inflammation, pain that you have. Sometimes it actually can, if it keeps progressing and the person doesn't do anything, it can actually spread to lymphatic system, because from the tissue it gets sucked up to the lymphatic vessels. So then you can actually see the lymphatic vessels getting red. We call that lymphangitis. So it could be, again, most of the times it's caused by bacteria. The typical bacteria that causes it is Staphylococcus aureus and Streptococcus pyogenes. That can be found normally on anybody's skin, body. Sometimes in infants we see group B Streptococcus. Streptococcus pyogenes is group 1. Okay, it's more severe. Group B is Streptococcus, can be actually found in the vaginal tract of females. So infants can actually get this during birth. How it's transmitted, how the person get it, like I said, most of the time is a trauma to the skin. Certain professions actually cause this, makes a person more vulnerable. So individuals who use their hands a lot and the hands are constantly in water, they're getting dry, wet, dry, wet. They use their fingers and they can get micro tears. So people, dishwashers, people who, like again, constantly are in the water and drying out and doing, so skin gets very tender. Individuals that have, like, bite the cuticles of their nails. Some people do this as a nervous habit. Rowers, professional rowers, because they're grabbing that oar very tightly, which can cause little micro tears in their skin, especially if their hands are dry, and they're constantly in rivers and in lakes where there is a lot of bacteria. They can get this. So it basically that's the reason. It is very rare to see it in a healthy, normal person that, you know, doesn't have these kind of occupations. Treatments, mild ones, they just basically can get topical ointments to them and it goes away. In more severe ones, you probably have to give them oral antibiotics to get it systemic. If it is very severe, then again, make sure you remove the pus from the area, remove the bacteria, and clean the area where they have it. For an immunocompromised person, this can very easily lead into, all right, I gotta remove part of your skin. But again, these are very rare. Folliculitis. This is from hair follicles. Most often, damage to the hair follicle, hair shaft. So, very tight ponytails. Very tight braiding of the hair. You know how they do that, or they use that tight braiding to add extensions and things like that. For men, tight shaves, like getting a very tight shave for the haircut and things like that. That can actually damage the skin and the hair shaft. Opens it up and the bacteria goes in there. You usually start with little pimples like that, and that spreads very easily. It's itchy, it's scratchy, you scratch it, it spreads and goes to the other areas, and then it can actually create boils and things like that. Your eyelashes could have it too, and that's when we refer to it as a sty. Okay. So, from those little tiny pimples, it can become to these boils. The technical terms for it is furuncles and carbuncles, so it can become like that. All these diseases of the skin very easily spread by the person themselves because they keep touching it. And it can spread to somebody else when their hands are dirty. Something like this, again, in most cases, the person usually has a lower immune system for whatever reason. Most normal cases, if you have it, one little pimple, you can actually open it up, put a little bit alcohol or Neosporin on it, and it's gone. But for those individuals, some individuals based on their genetics can go further. And again, so with every infectious disease, keep this in mind. This is not for general population. It doesn't act exactly the same. You could have a tight ponytail and never get this, right? It can be genetic. It can be the type of the bacteria that is there, strain of the bacteria, the health of the person, the genetics of the person. You can have a virus in you and it won't do anything, like you saw with COVID, asymptomatic individuals. We don't know why, but it could be different. Causative agents, again, Staphylococcus epidermidis in most cases, and in some cases Staphylococcus aureus. So see, you've seen Staphylococcus aureus twice now. That's why I say write these separately, and for aureus, so for example, you have cellulitis, folliculitis, it will cause this, so you know it. All right. Diagnosis, most of the time they look at the area based on where it is. They can make a diagnosis. They can actually take a sample from the vesicle, put a gram staining on it. They see a gram positive bacteria. They decide on it. For treatment, you always drain the pus out, and then again, antibiotics, either topical if it's minor or oral if it's severe. Next one, this is a specific Staphylococcus strain. This is a Staphylococcus aureus, a specific strain that produces an exfoliative toxin. So it's not a normal Staphylococcus aureus. It's a Staphylococcus aureus that produces an exfoliative toxin. What the toxin does, it basically causes epidermis to completely move away or be peeled away from the dermal layer. So it makes the dermal layer, exposes the dermal layer. We see it in immunocompromised individuals and infants, newborns, and elderly, because their immune system typically is weakened. A newborn doesn't have a strong immune system, and elderly, as they get older, their immune system doesn't function properly. So what it does, like you see it here, it actually removes the dermal layer. It's called staphylococcal scalded skin syndrome, SSSS. Okay, so scalded because it looks like the person has been burned, and then they had a blister, and the blister is going away. How it's passed on, and that's bad part of it, is a person with a strong immune system doesn't see it. So they can have it, and a patient can have it before showing the signs and symptoms. They take care of that baby, for example, in the nursery. They go grab another baby, and without knowing it, because they think the babies are clean, they pass it. Same thing at nursing homes. And suddenly it spreads all over. In babies and infants, the prognosis is pretty good. You have to, in both cases, give them IV antibiotics. But in an infant, their skin is designed to reproduce and replicate. So they don't even get scarring. You just have to make sure that they are now in a clean environment and they don't get exposed to anything else that can get inside. For elderly, their skin doesn't regenerate that easily, so scarring is possible, and unfortunately, if they are in a situation that is like that, they are in an environment that is already is a healthcare facility that is totally, they're exposed to all these different bacterial and all of that stuff, pathogens. So secondary infections are more common, so we have to be more careful with them. Obviously, isolation is another thing for the patients. So they have to be isolated in a clean room and IV antibiotics. All right, impetigo, or pyoderma. Now, this one has different degrees. The images that I have, this is the more severe case. Impetigo, you can actually see it in children during winter time when it's very cold, and they tend to keep licking their lips. You know how the lip and the upper area of the lip, between the nose and the lip, gets really red and dry? That's a form of very minor impetigo, okay? A child who's recovering from cold can get that. Usually that's, again, could be because of bacterial infection, and in some cases it's just irritation of the skin, and just using Neosporin and then hydrocortisone to lower the level of inflammation works fine for somebody healthy and all of that. These, like I said, is a severe cases. So again, the severe signs and symptoms, red patches starts, and then the red patches become a vesicle. When the vesicle ruptures, then you have this yellowish brown crust going all over. And for the severe immunocompromised, it spreads very fast. It can go to see something like this. It can go to some severe form like that. Staphylococcus aureus and Streptococcus pyogenes, most often the cause. And again, it tends to be because of, it spreads because they have dermatological issues like eczema, psoriasis, where their skin is not actually good, so it spreads it. They can get infections like that. In children, like I said, dryness of the skin, sudden changes in temperature, how it makes one skin drier, travel to areas where the skin is, again, irritated. Treatment, topical antibiotics, or in severe cases, systemic antibiotics. Prevention, avoid touching it and spreading it to other areas. which is hard because it itches. Now, anthrax. This is cutaneous anthrax, and the reason I cover it here, we don't see it as much anymore because of the vaccination of cattle, but we have a lot of little farms around here. And in California, especially in Central Valley, we have a lot of farms, cattle farms. Anthrax, Bacillus anthracis, is a bacteria that is very naturally carried by cattle in their digestive system. So you could see cutaneous anthrax. That's when a person has this cut and the anthrax, the spore for the anthrax gets into the skin and causes it. It's a very, when you look at it, you're like, oh my God, that is horrible. But it's funny, it's painless. The center is necrotic, kind of looks black with raised edges, but it is painless. And it responds very well to antibiotics. They just have to make sure they clean the area. They can put actually topical antibiotics and give the person oral antibiotics and they're okay. This is not what kills people when you worry about like anthrax being used as a bioweapon. That's the spore inhaling the spore, okay? This is the bacteria or the spore gets into the area. Like I said, vaccination of cattle has stopped it. There is a human vaccine for it, but they don't give it because it doesn't have, first of all, a great efficacy, and then second, how many people are in danger of getting this? The one that we always are scared of, necrotizing fasciitis, in hospitals lovingly known as nec fasc. Saying the whole thing is too much. Nec fasc, or what we know in everyday term, flesh-eating bacteria. Okay, there is a large group of them that can cause it. The most common one was Streptococcus, now Staphylococcus aureus, the MRSA, MRSA. MRSA is MRSA, methicillin-resistant Staphylococcus aureus. It tends to be that one too. What it is like I said, a group of bacteria can cause it. Most predominantly is this one. Now we are seeing Staphylococcus being as part of it too. What it does, it gets into the skin. First, it's kind of like you don't even notice it, and you don't even have to have a vesicle of it. But many times it's a little tiny pimple. That little tiny pimple now decides the round of it, it gets redder and redder, and then it starts becoming very painful, becomes into hemorrhaging of the area. So what it does, it keeps spreading and it causes necrosis of the tissues because your body is reacting to it and the infection is spreading. So the inflammation is so severe, you have necrosis or death of the tissue. Necrosis or necrotic means death of tissue. So then it reaches the muscle fascia, and that's when it's extremely painful. So these are okay pictures. There are more severe pictures, and I usually don't put those, but there are more severe. So when it spreads like this, then the only treatment is first and foremost, remove the necrotic tissue. You have to scrape it off. You have to go surgery and remove it and remove some of the bordering healthy tissues. Then severe, long-term antibiotic treatment. In many cases, it might have to be cocktail of antibiotics depending on the strain. And the person is attached to this IV for a long term. The bad part of it is you cannot close the scars or the area that you've removed the tissue from. So you have to leave it open because some of them that are anaerobic, now it can actually lead to necrotizing fasciitis and gangrene and even worse. So you have to leave it completely open, which means severe scarring. In some cases, the hyperbaric oxygen therapy, they use that. They use them in special tents. They use it in by changing the pressure. Actually, they might be able to slow down the growth of the bacteria and then give it more oxygen, things like that. In some cases, unfortunately, if it keeps spreading, amputations can happen, and then further and further, it can cause septic shock and the person can die from it.
Is this the stuff that you can get in like the gyms?
Sometimes some people have been known to get it from the gyms. Carpenters are prone to it because they keep getting like this little splinters and stuff that they don't pay attention to. People who, like stories you've heard, they go to zip lining and they get it from zip lining, or they've gone on vacation to a place that it's not very sanitary, and just by walking in the street and getting a cut on their foot or stuff, they get it.
I got it at a gym. I
So-
believe so.
But it wasn't necrotizing fasciitis, was it?
It started to spread, but it was painful. It felt like
But they didn't have to remove.
they did not. They just put me on a lot of antibiotics.
So that's more like cellulitis,
okay.
kind of it. If that spread and it kept causing necrosis, then that would be necrosis.
Yeah, it didn't heal normal.
Yeah.
I still have scars.
Yeah, it takes a while. All right. So prevention, any little thing that you have, always pay attention to it. Any little vesicle, pimple, any little cut you have, don't think, it's okay. Just take care of it, make sure you clean it properly and all of that. All right, next one, Pseudomonas infections. Remember, Pseudomonas aeruginosa had none of our antibiotic discs work for? So, good news, very hard for it to pass the skin, intact skin and healthy skin. Bad news, it can be found in a lot of places. Bad news, if it gets inside, it's very hard to get rid of. So, Pseudomonas aeruginosa, for those of you guys who had it, you saw that little lovely green coloring appearing, right? So it produces that green pigment, it's called thiocyanine. If it gets under the skin and then past the epidermal layer, then it gets into the tissues. So for example, you could have those green nails between the toes, it can grow. And some severe cases, we actually had, I think this was 7, 8 years ago, people that were getting hip implants. For a group of them, they started getting Pseudomonas aeruginosa systemic infection and dying from it a few months after it. And when they researched, unfortunately, the implants were infected. So they thought it was, so they obviously took that out. But so you see it typically simply like everyday thing in burn victims, victims that have a motorcycle accident and they have like half of their skin is like road rash is gone. So severe skin damages, you see it. So that's why they have to be protected. They have to make sure they change the gauze constantly, make sure it's clean and all of that. Sometimes you see it actually changing the gauze into green color. Once that happens, you have to give them, again, a cocktail of antibiotics via IV for a long time and hope that it will respond. Okie dokie. Gas gangrene. So we call it gangrene means when the tissue starts dying. Typically, it's a surgical or a deep cut that you have to the tissue, and it happens after you close it. So you suture it or however way, that deep cut was closed and it wasn't cleaned properly. In emergency rooms, we can actually see it because of surgical issues. Sometimes it still can happen. Or in many cases, the person comes, they haven't had surgery, they come like gang members. We see it a lot. When they get shot or stabbed, they don't go to emergency rooms. Why? Because they have to report that. Any stabbing, any gunshot has to be reported to police. So they don't want to do that. So they go and somebody takes care of it. But if they don't clean it pretty well and they suture it for them, within a day or two, they come back with a gangrene. Gas gangrene, we call it because it turns extremely red. It is extremely inflamed. It starts bubbling. it produces, when it ferments and it produces these gases, carbon dioxide and all of that, and bubbles, and it smells horrible. It smells like a total decayed skin. You know, what people think of like dead animals, it smells like that. So it's very bad. That's why they call it gas gangrene. Treatment for it, immediately open, remove the gangrene or necrotic tissues, leave it open. And then prescribe antibiotics for the person until that thing starts, the scar starts healing on its own without, you cannot suture it again. Again, can lead to amputations. All right, so those are bacterial. So this is why I said, as you saw, Staphylococcus aureus, Streptococcus pyogenes, especially those two, make sure you know what diseases they cause. So on the test, you're not like, oh my God, was it strep? Was it this? Was it that? So, viral infections of the disease. Many of these, like as you saw, bacterials is skin to skin, damage to skin, so you come in contact with the bacteria, right? With viral ones, it's interesting. It could be direct contact, like you see in warts, regular warts, or it could be actually respiratory. Measles, mumps. Mumps is not skin. Measles, rubiola, same thing, or rubella, German measles. Smallpox, these are respiratory, but it will have an effect on the skin. All right. Okay, first one, warts. So not genital warts, we're talking about regular warts, which is funny. Kids tend to get it more than adults, and then it's like it goes, as they get older, they never get it. So when they're kids, they can get it multiple times, and then as they get over it as they get older. It is caused by human papillomavirus, HPV. The strains that cause the epidermal warts, the skin warts, those are different strains than the ones that cause genital herpes. But they are close enough that when you get that, for genital herpes, there is a vaccine for it. It can actually protect them from regular warts too, they say. What happens? The virus gets into the skin, and again, you can test the person, and the person shows antibodies for HPV, but they've never had warts or anything else. It is a very common virus that is found out there. Not everybody gets it. Within a family, you see one kid keeps getting it, the others interact, play with one another, nothing, right? What it does, it gets to the epidermal layer and causes the rapid division of the epidermal cells. So you get that little raised tumor, and that's what the wart is. And people say, look, oh, my wart had a baby. Because you itch it, you put it somewhere else, that cell gets it too. So that's how you transmit it. It's skin to skin. Treatment for it is simple. Kill the cells that are infected, you're good. So before, in the old days, you had to go to the dermatologist's office. Nowadays, you can actually buy those special cans at Walgreens, CVS, and do it. So surgically remove it, burn it, things like that. Old days, it really works. They would take the wart, and especially like on areas that you could lift the skin, they would lift it, then tie it really tightly with strings underneath it. What that does, it prevents blood from getting to the wart. Those cells die, the wart falls off, you're gone. Other things, duct tape. They've done research on this.
It actually works.
It works, not always, but it can work. Again, they think it's because it prevents oxygen or something going on. Figs sap does not work. Windex doesn't work. But no, seriously, there's a research paper on these things out there. Now, again, like I said, Gardasil can provide it, but they're totally different strains. Just because a person got skin warts doesn't mean they will get genital warts. That's STI, it's the sexually transmitted infection, it's totally different. Now this thing that we have, This is a man in Malaysia that warts grew on his skin so much that this is his hands. He's dead actually now, but he got this at 19. There is a video on it. If you search Day Day, the tree man, they show it, that doctors removed all of the warts and he looked normal, like normal fingers and everything. But they believe it's vitamin deficiency in him and some other immune deficiencies that cause the warts to be like this. So he wouldn't be able to do anything with his hand. But as soon as they remove it, he's okay. For a while they can slow it down, but it always kept coming back. And he died eventually. Okay, next one. Very common, chicken pox. Not as common anymore because everybody's getting vaccinated. So you do see it every now and then because the person doesn't get immune for it. The technical term for it is varicella. So even on your immunization records, if you see, sometimes they have actually varicella and not chicken pox. That's the same. It's respiratory, so you breathe it in. In the old days, they had chicken pox parties. One kid got it, they put you together. That's what happened with me and my cousins. One of my cousins got it. My mom took me and my brother and I, and then the rest of the cousins. Funny, never were allowed to play with somebody who was sick. We were all in the same room with the sick person. All of us got chicken pox because they want to get rid of it completely. So that was the old ways. Now you have the thing for it. In children is way weaker symptoms, the pox. So it basically, you get the pox on chicken pox on the skin. It starts with a fever, kind of a sore throat, headache, and all of that. And then you have these little vesicles breaking over your skin, and then they crust over. The key thing is just don't scratch it, which is hard, especially in adults. It's very itchy. In kids, it's not as bad. And it's basically once they go away, the person is okay. No treatment for it, just supportive. Again, taking care of the itch and all of that, making sure the kid is hydrated. By the way, in any viral, this they learn later on, in any viral infections, you do not give a child an aspirin. Aspirin can have an effect on liver, and many viral infections can have an effect on liver. It can cause damage to the liver, so you don't give them aspirin. Ibuprofen is good, acetaminophen is good, so Advil, all of that, just no aspirin. The person is good. We have for prevention an attenuated vaccine, works beautifully for majority of people. Prognosis, if you have had chicken pox, for about 10% of the population, the virus suddenly goes latent into the neurons of the skin. Later on in life, those neurons can get like agitated or something like that, and that causes the virus to come off of latency, start reproducing, damage those neurons, and that causes shingles. Shingles is extremely painful. You could have the rash or you could not if the nerve is too deep, and it usually causes issues of concern in the patient because the patient goes and the doctor says you have shingles, and they're like, but I don't have any rash. They're like, trust me, you have shingles, and the pain is enormous. So they're like, this can't be just shingles. It takes about 2 to 3 weeks. Rare cases, children can have shingles, mild case of it, because of the vaccine. It is very rare to do that. You technically, people who have shingles get it because they had chicken pox. So chicken pox is all over the place. Shingles is in one area. If you're not immune to chicken pox, when you're near a person who has shingles, you will get chicken pox. Would you get shingles later on in your life? We don't know. It's your genetics. All right. Measles, the medical term for it is rubeola. Measles was almost gone from industrial societies like United States. then people started questioning the vaccine MMR, measles, mumps, and rubella. And now we see it, and California is actually a hot spot because of Disneyland, because of San Diego Zoo, Legoland. Southern California is a hot spot for the rest of the United States. During COVID, it got less because people weren't going out. But then again, we're expecting to see it every summer and all of that. It is a respiratory one. The name of the virus is the measles virus. It belongs to a family, Paramyxovirus. So it's a measles virus, respiratory. It starts with a little bit of a dry cough and fever and all of that. Then you have the red and reddish bumps. It's not a vesicle film, it's bumps. Bumps and like a raised part of the skin. So it's a papule. Where's the image? So see, like this, a little bit slightly raised and all over the body. Usually, it can go both ways. It can be very dangerous. If measles gets inside and disrupts the respiratory system or gets into central nervous system, the virus, then it can actually cause death. Majority of people recover, but the chances of death from it is actually not extremely low, but it is possible. This is why people say, oh, it's measles, it's nothing. I'm like, yes, for you it was nothing, but it could be for a child. Nowadays, especially with their lower immune system and like, lack of normal flora and all of that, you don't know how it's gonna react in a child. It is, again, no treatment, supportive care. Take 2 of these, go home and call me in the morning, hopefully you're fine. Usually it lasts about 10 days or so. Now, German measles or rubella, that's where the R comes. Measles, mumps, rubella. German measles is, again, kind of the same thing. It's respiratory, it's a rash. The rash is a little bit different. See how it creates blotches and patches of it? It's not tiny little red dots like measles. These combine together and almost creates like little blotches. And you see it more for German measles around the neck and upper thorax area, whereas regular measles is all over. It is extremely mild, no death associated with this, and the child or the person usually recovers within a week or so. However, it is extremely dangerous for a fetus. So for pregnant women, this was dangerous. And this was dangerous because if their child got it and they were in the, especially like the 2nd or 3rd trimester, it could have an effect on the fetus, and it has neurological effects. So it basically, it's the 1st trimesters. First, the beginning of 2nd. So when the nervous system is developing. It can actually cause severe fetal damage to the point that it's miscarried. In other cases, mental retardation, blindness, deafness, so all of those can actually happen. All right, next one, smallpox. First and foremost, this is the #1 infectious disease that has been eradicated successfully from human population. Only reservoir was humans. World Health Organization actually got together, very old vaccine, that's the one that Jenner created, by using the vaccinia virus for cowpox, and provides beautiful immunity in majority of the public. World Health Organization in 1970s, late 1960s, basically provided the vaccine for the entire world, and everybody was populated for a long term. And they they monitored it very closely and made sure that everybody was vaccinated, and it disappeared. On its own, the disease is actually very devastating. It's respiratory, and this is what it looks like. So you start kind of like this, go here, here, and here. She has has this, these are like one of the last, this is actually a child that survived it. So in severe cases, not only it can damage you because it basically scars you. Read old novels from Europe, romance novels. They will have like, this woman was married to this very nice and beautiful guy, and she was always devoted to him and wouldn't do anything in all the romance novels. Why? Because she had the pox face, and she was scarred by smallpox. Queen Elizabeth the First, that had that white, always she painted herself white, was because she got a mild form of smallpox, and she was covering that with that thick white paint, and she kind of came up with it, and everybody was trying to like do as the queen does, but it was because she had those poxes. It can kill you because that gets inside, and severe infections, and damages your respiratory system, things like that. So it wasn't just on the skin. No treatments that we know. Back then, when people were still showing it, they tried like giving them back the vaccine early on. It didn't work. So unfortunately, you either get the mild form or the severe form. We haven't seen it since last time in United States was 1975. In the rest of the world, 1979, they stopped vaccinating, and they haven't seen it since. By the way, the vaccination process is very interesting. It's not an injection. They take a little disclet that has sharp prongs to it, and they jab you with it. So they have little scars in a round circle. Then they put the drop on that. That is supposed to scab. And then you're supposed to go show it to the doctor, and they're like, no, we got to do it again. The scab is not thick enough, so they do it. Usually they did upper arm or upper thigh. So individuals will actually have that. I was born before 1979, obviously. So I actually have it on my arm. TB is done the same way too. So some of the people that are younger were born some other places and they get the TB, they will have that too. They don't have smallpox. Some of our soldiers after 9/11 were also vaccinated. Not all of them, but some of them and all of them. But, so that's what it looks like, the little round discs that you see. But TB does that too, so if you weren't vaccinated, so they have stopped vaccinating the world. Other viral rashes that you can see, these are funny ones. The fifth disease is erythema infectiosum. It sounds like Harry Potter's thing, right? But this thing is funny. It's a respiratory. The person gets a cold, and then suddenly you have this rash on your face that looks like somebody grabbed their hand, open hand, and slapped you the hardest way. It looks like a handprint on somebody's face. And sometimes in some places they actually would call the social services. And like, this kid was slapped. It's like, no, the kid has fifth disease. So that's a common one that you see that shows up. Again, it's respiratory. It shows up as a rash. The other one, it's the cause for worry for new parents that have never heard of this. Roseola. It's usually children get it, about ages of, adults can get it too, but children tend to get it. The symptom and sign starts with kid is fine, high fever, or a fever for 24 hours, nothing else. So you're like, why is my kid having a fever that is pretty high, because they're very also get tired, but the fever we're talking about 101 and sometimes 102. No other symptoms. So it's all, fever is always worrisome. And then as soon as the fever goes down within 24 hours, the stomach gets a big red rash. They call that roseola. So that first 24 hours is very hard because you're like, okay, I hope it's nothing serious. But these are like some of the side ones. Usually pediatricians know more about this than general public. Fungal infections. Fungal infections, first of all, few things about fungal. study of funguses, so bacteriology is study of bacteria. Virology is the study of viruses. Study of fungi is called mycology. And fungal infections are called mycosis. Again, we talked about fungi, so it could be yeast or more molds causing, and most of the time yeast is the one that gets into our system. We could actually have molds. There is one that I didn't put up there, like it could be mold on the nails, the hair. There is one disease that is called Piedra Noir, something like that. It's a black mold or a white mold that is at the base of your hair, where the hair hits the scalp. And the only thing that you have to do for a treatment is just shave the person, and the mold falls off. So there is mold possible. But what we look at, the classification, is either superficial. So you have it just on the surface, on the skin, like diaper rash. That's superficial. It can become subcutaneous. So rather than epidermis, now it's damaging the whole epidermis, it's getting to dermal layer, okay? Or systemic. That's when you have it, like for example, respiratory system, it gets into the blood, that becomes systemic. For the skin, the superficial ones, diaper rash is one that we're going to talk about. So diaper rash, it's usually caused by Candida and Candida albicans, that is normal. Typically in the area got really wet, the skin is vulnerable, so the fungus, it provides an environment for the fungus to grow more faster. Most often children, by using creams like Desitin that has zinc and then also can create a barrier between the moisture and the skin, they're okay and they're fine. Sometimes in some cases kids get more severe kind of it. So we don't call it diaper rash in adults, but again, adults can get that also too in the growing region and all of that if it's wet. It's not off the skin, but thrush that you get on your tongue, that it layer fungus grows. Again, that's kind of like a superficial, all right? Now, the most common ones that we see is the dermatophytes or subcutaneous. Athlete nails. Okay, so the nails get like that. Athlete foot, where you could actually get scarring between your toes because of the fungal growth. And very common in individuals because again, your foots are in a warm environment, humid. Ringworms, these are all subcutaneous. So they pass the epidermis and they get to the dermis layer. Typically what you do is based on what you see, you can diagnose it. They can actually take samples and look at the samples with KOH and all these other type of staining and look at it. The spread is most often contact, direct contact. So this is why we say don't wear somebody else's shoes without protective measures. Don't walk into a shower at the gym, wear flip-flops, because that environment with the ties and all of that, your skin to top layer can peel off and then basically like normal shedding, and you can have the fungi there too. So it can provide it if you have the right environment. Your foot has a scar or something. Kids with ringworm, they are supposed to cover it if they're going back to school. You can get ringworm from your friend because you touched them, you wore their shirt, you were in the same bed, things like that, okay? So have an idea of it. We're not talking about anything that's systemic associated with the skin. And this is the last slide. Usually if I have something like that, it depends on the terms. I might decide, okay, I'm going to talk about the disease is appearing, or we haven't seen this disease in a long time, so I'm not going to even cover it. So anytime you see that deleted slide, ignore it, don't go beyond it. All right? Questions for me? Okay. All right, guys. So I'll see you guys on Monday in the lab at 11. first we're gonna clean the drawers, and then we'll do the lab. Then we'll come up here, talk about diseases of the nervous system, and so on and so forth. All right? Okay. Have a good weekend.